a lot of exciting results that are on the horizon, and a very interesting story that she's built over her short career already, leading to some very exciting work on the horizon. So please join me in welcoming Julie Scialla.
Thank you. Thank you. Thanks for the kind introduction. So I hope today will give you an overview of my research program, some of my background, and where I want to go as a new faculty member here at the DCRI. Not sure if that's... Well, there we go. So I'll talk to you today a little bit about diet and physiology and its role in controlling the rate of kidney disease within a population and the progression of kidney disease in a patient. I recognize that the audience may be a mixture of clinicians and non-clinicians, so I'll try and give you a little bit of background first about exactly what I mean by chronic kidney disease and what some of the physiologic derangements are that we'll be talking about, what I mean in terms of shifting the curve, and then we'll move into specifically speaking about an area that I've worked extensively in the last several years on phosphate homeostasis in kidney disease, an area where I've been working and will continue to work here at the DCRI on acid-base homeostasis, and we'll close with a few applications of how this could be relevant for population health and for patient care. So probably most of you know what kidney disease is. I'll say the concept of chronic kidney disease is actually relatively new in our field. Nephrology focused almost exclusively on very advanced kidney disease, dialysis and transplantation for many years. And it wasn't really until 2002 where we came up with a definition of what we meant when we were speaking about chronic kidney disease, sort of earlier stage kidney disease. And it was initially defined by National Kidney Foundation Working Group as abnormalities of kidney structure or function that had to be chronic, so they required at least 3 months duration. And what we mean by kidney damage, usually, most commonly this indicates abnormal levels of protein, particularly albumin in the urine, which can show sort of increased permeability of the filtration barrier, effects of the kidney, changes in acid-base, metabolic acidosis due to the effects of the kidney on maintaining acid excretion, changes in mineral homeostasis and bone disease due to the effects of the kidney on calcium and phosphate, and malnutrition, essentially due to a variety of factors when you suffer from a chronic disease. But the idea of CKD is recognizing that many different sequelae, many different diseases can give rise to a common syndrome. And what's important about this syndrome, other than its complications, is that once initiated, it tends to be progressive. So despite what the initiating cause may be, a injured kidney or a remnant kidney model, if you look at an animal model, will continue to function. Even if you control their hypertension aggressively, even below current norms, the kidney disease is progressive. And so this is an observation that I think has stimulated a lot of people to think about what are the pathways that promote ongoing progression. And then, why is kidney disease important, and why do we worry about even early stages of kidney disease? These were some seminal observations from about a decade ago that came out of Kaiser Permanente of Northern California. So they looked at 1 million enrollees within their healthcare system and looked at their initial estimated glomerular filtration. Thing. They had all the cohorts analyze their data in a standard way with sort of predefined statistical programs so that everyone was using the same covariates and looking at the same cut points and the same information. And then they did a random effects meta-analysis and looked at the impact of GFR and albumin to creatinine ratio in the urine across a wide swath of kidney function. And basically, here you're looking at all-cause mortality according to GFR. So here you're in the normal range of GFR. This is normal for healthy young adults. This would all be considered still relatively high. Early evidence of CKD damage, stage 1 and 2, are also quite important. And the reason I bring this up is that as physicians, we often think about patients here in the red zones. And we're trying to identify patients that have severely reduced GFR or albuminuria or a combination of both that are at very high risk. So this red zone here, as defined by KDIGO, is a zone that's at extremely high risk for ESRD, cardiovascular events, or acute kidney injury episodes. And this is usually our mission as clinicians. But when we begin to think from a population health standpoint, there are a lot of patients in the yellow and orange zones that have mildly increased risks, but that that may not have high risk for going on to ESRD, but what we miss is that the entire population has susceptibility to disease. And so in trying to identify risk factors within a population, we may miss a ubiquitous risk factor that's affecting all of us. And by shifting this curve, we may also mitigate a lot of the impacts of these risk factors on disease and lower population prevalence of disease. So can this kind of paradigm be applied to CKD, and is that appropriate? I guess the first comment on that is that we have a growing recognition of how common CKD is. So this data is from the National Health and Nutrition Examination Survey. If you're not familiar with that, that's a generalized in 1999 to 2004. So again, this is 1 decade of time, a statistically evident change in GFR as a nation towards less favorable values. And if we think here about people that have CKD, it would be this small population area under the curve here, which in our 2004 at least was 13% of the population. But if we think more broadly about risk that's continuous across the spectrum of GFR, we see that there may be a lot of disease that could be prevented. That's reiterating, so we'll move on. So I hope I gave you a little bit of an insight about what I mean by CKD and a new hormone, which we call a phosphatonin, fibroblast growth factor 23, that has a very primary role in maintaining normal phosphate levels despite differences in diet and kidney function. So FGF23 directly stimulates excretion of phosphate in the urine, and it also impairs absorption of phosphate in the gastrointestinal tract by limiting vitamin D. So it directly inhibits a conversion of nutritional vitamin D to the active hormonal form, which is needed to absorb phosphate in the gastrointestinal tract. So as a whole, FGF23 maintains normal phosphate by promoting its excretion and minimizing its absorption. And we've known, since its discovery that FGF23 appears to rise in kidney disease. So there are a number of cross-sectional studies that have looked at where exactly FGF23 begins to rise at what level of GFR. This was certainly not the first study, but was the first study to look with multiple repeated measures within individuals and show that measures actually were rising within individuals followed over time as their kidney disease progressed. So here we went back to the ASK study, which I introduced to you earlier. Again, this is the context of a clinical trial where the intervention was on blood pressure. But we took a look at what was happening to mineral metabolism as patients progressed in this study. And so we measured FGF23, which is this phosphate regulatory hormone. We measured PTH, which is another hormone we won't focus on, but that regulates phosphate. And so summarizing that, what we've learned from those studies is that FGF23 here shown in red is a hormone that rises quite early in kidney disease, even when GFR here is relatively normal. Again, low GFR we usually start discussing at around 60. So FGF23 is rising relatively normal, and it's causing a decline in vitamin D levels, which is one of its physiologic effects. And in conjunction with PTH rising, FGF23 and PTH keep phosphate, here shown in light blue, completely under check through most of chronic kidney disease, really until late stage kidney disease in a decade. So enrollment began in 2003. This was a cross-sectional look at the relationship between FGF23 and left ventricular hypertrophy done by some of my former colleagues. And as FGF23 increases, you can see that left ventricular mass increases. And here the proportion with normal left ventricular geometry, shown in white, is decreasing. And different abnormal patterns, either remodeling, concentric, and eccentric LVH, all being present to a greater extent. I won't show you a lot of the basic biology, but colleagues of ours have looked at these factors to understand whether this is a direct effect or whether this is confounding. And certainly, at least in these isolated rat ventricular myocytes, you can see that incubation of cells in rising concentrations of FGF23 shows hypertrophy of the cells, similar to what you see with sort of the prototypical FGF2, which is a well-established inducer of hypertrophy. There are other models that shows this happens in vivo as well, and really quite interesting as to whether FGF23 could be one of the links between CKD and cardiovascular disease. one of the problems with this hypothesis is FGF23 has a very important physiologic role in kidney disease. So although it may have some adverse effects, FGF23 is critical for maintaining phosphate. And it's well known that phosphate has adverse effects in kidney disease as well. I had CT scans where we could measure Gatson scores, or scoring criteria for coronary artery calcium. And we also had, in the vast majority of participants, information on hard clinical outcomes, so atherosclerotic events that were adjudicated and congestive heart failure events that were adjudicated. And so first, just showing you the coronary calcium data. We'll focus here on the fully adjusted model. So coronary calcium, if you haven't worked with it, it's a difficult variable because it's heavily zero inflated. So you have 45% of patients. We had corroborating evidence from cell models that were done by some colleagues showing here that high phosphate concentrations induce calcification. So the y-axis here is calcium deposited here in vascular smooth muscle cells from humans, here in mouse aortic rings. But high phosphate concentrations in both model types could induce calcification, and those weren't modulated by FGF23. So just corroborating the possible sort of causal nature of some of these associations that we were observing. So the next obvious question is, how does this translate to patients and event status? So we looked at event types separately. So we looked at atherosclerotic events with the hypothesis that they would be less related to FGF23 and more related to phosphate, compared to heart failure events, which we hypothesized would be more tightly knit to FGF23. And the long and short of it is here for atherosclerotic disease, higher FGF23 was associated with higher risk of atherosclerotic heart disease. Here, this is the rising quartiles. When you looked at an incident-only analysis, so excluding patients who had atherosclerotic cardiovascular disease at baseline, you lost significance, but the shape of the association is relatively similar. But what we thought was interesting is if you excluded to just definite events, where you only include patients who had stricter criteria, so they may have had evolving EKG criteria associated with progression to ESRD in that study. So we went back to ask, again, this is that same trial, blood pressure intervention. We measured FGF23 in 809 of the approximately 1,000 participants in ASK, where we could obtain year one blood samples. And we used year one to give us some distance from the randomized intervention and whatever effect that may have had. And then we had repeated assessments of measured GFR, as I mentioned to you in ASK previously, and we're able to follow the relationship between FGF23 and outcomes, really gold standard measures of kidney function over time. And suffice it to say, higher levels of FGF23, shown here in quartiles, were associated with a very high risk of progression to end-stage renal disease or death when you just had demographic adjustment. Adjustment for GFR attenuates a lot of that risk, but certainly not completely. And adjustment for many other variables, prior cardiovascular disease, other mineral metabolites like phosphate, or the trajectory of GFR decline over the first year of the trial before we measured FGF23, you really don't attenuate this any further. So we saw really a robust relationship between FGF23, risk of end-stage renal intervention. So if you look at what physiology would occur in a high phosphate diet, so what we believe happens when you eat a high phosphate diet where you have high levels of absorbed phosphate, you're going to stimulate FGF23, and you're going to have mild increases in serum phosphate, largely kept in check by the hormonal controls, FGF23 and PTH. But in a low phosphate diet, we can lower FGF23 without changing phosphate, as we would with a biologic. So I think when we have a physiologic pathway that we need to intervene upon, the hormone, although it could be detrimental, needs to be targeted through that physiologic pathway. And modifying diet is one way to do that. And there are several ways this could be done. Some of the easy ways are by targeting phosphate additives in food. So there are a lot of phosphate additives that preserve shelf life, as I mentioned. Currently, these are ubiquitous in the food supply, and they're not particularly labeled. Phosphate may show up in the ingredient list, but it's not required that phosphate in terms of number of milligrams in a food item is on the food label. So even patients who may be advised to watch phosphate by their doctors will have a difficult time doing so. Other possibilities to attack this pathway through food is by focusing on access to healthy foods. So highly processed foods are going to have much more phosphate than naturally occurring unprocessed foods. But access to food is not widely available to all individuals, and to monitor this. We're going to miss patients here in early kidney disease where there is a sort of rising risk, but it's still a low-level risk and one that's probably not clinically very apparent in most individuals. And it's not until late in kidney disease when the rates of frankly obvious acidosis are widely present in patients with CKD. So one of the questions is there a marker of acidosis that could help us target this pathway earlier, similar to FGF23 and phosphate? And is that important? So I'll show you this work, not by me, but by Don Wesson's group, that tried to, that really provoked the question of whether there was derangement in acid base occurring early in kidney disease that we were missing with the bicarbonate, with our current readout variable. So this is a small physiologic study. Let me show you what they did. So they took patients who had very early kidney disease. So stage 1, these are people with protein in the urine, normal GFR above 90, and compared them to patients with stage 2. So again, GFR relatively preserved between 60 and 90, but protein in the urine indicating kidney damage. And they looked at these patients and they fed them actually nothing was done, I don't believe. And they looked at acid excretion in their urine, and both groups of patients were excreting about 25 milliequivalents of acid in their urine over 8 hours. So this is physiologic and normal. And they looked at their serum bicarbonate concentrations, which are important because of a few very small trials that have been done in patients with CKD. This one is only 134 participants. They had late-stage CKD and clinical metabolic acidosis with low serum bicarbonate concentrations. These patients were treated with either bicarb supplements or not to normalize their bicarbonate concentrations. And those treated with bicarb supplements had a slower progression to dialysis than patients that were not treated. So suggesting perhaps there is a benefit to normalizing this pathway in an extreme setting where CKD is advanced and acidosis is obvious. But what about in a less extreme setting when CKD is early and acidosis is not obvious? So this was another small trial. I believe it's about 150 individuals with stage 2 kidney disease that were treated with sodium citrate. They had normal bicarbonate at baseline, but it says sodium bicarbonate, sodium bicarbonate, which is a base. They had normal bicarbonate concentrations at entry, just hypertensive early stage kidney disease. And so they had a group of patients that were treated essentially placebo, a group of patients that were treated with sodium chloride as a sodium control, and then the group of patients treated with bicarbonate in the dark solid line. And you can see that the GFR trajectory over 5 years of treatment was attenuated in patients treated with bicarbonate. And it didn't matter if you looked at, this is a sort of a technical thing, but whether the GFR was calculated from a creatinine measurement or a more sophisticated measurement using a cystatin C biomarker. Either way, you got the same result, that bicarbonate was slowing the rate of progression of kidney disease in these patients with very. And if you take that animal and you give them CKD, so this experimental animal has CKD, they have a little bit of a problem generating ammonium in their kidney, but they make up for it largely by increasing how much acid they excrete through titratable acidity. And then if you challenge them with a highly acid-inducing diet, they are able to upregulate ammoniogenesis and maintain acid-base balance. But now if we think about this animal not as a total animal, but we think about it from the context of each nephron, and so the nephrons are the functional units of the kidney. So these animals have reduced numbers of nephrons doing this increased amount of CKD, maintain acid-base status, and appear normal, may actually contribute to progressive kidney disease in this conceptual model. So most of those studies have looked at use of alkali supplements to modify acid-base balance. And there's problems with that because they all require the administration of sodium to patients with CKD. And so are there other ways to modulate acid-base balance in CKD patients? And again, are there dietary ways to do that without giving patients sodium? So, one thing that we often neglect to recognize is that the amount of acid the kidney has to excrete is dependent on the inputs, on diet. So when we eat fats and carbohydrates, we generally metabolize them to CO2, and the lungs take care of that. But when we eat protein, that's metabolized to fixed acids that are not volatile. They're not excreted by the lungs, they're excreted by the kidney. And so the amount of acid that we generate is directly proportional to the amount of protein that we eat. And it's also proportionate to how many base precursors we eat. So we also ingest organic anions, which can buffer some of these protein bases. And those generally come in fruits and vegetables. So the amount of work that we place on our kidney depends on how much protein we eat and how much base we eat. And so we looked at this in the ASK study. We took 24-hour urine collections from the participants at the beginning of the study, and we used a biomarker of protein intake to estimate how much acid load they were providing and how much buffering capacity they took in by looking at the potassium. So basically you could estimate total acid production based on the protein, which would be an acid input, and the potassium, which would be a base input, because it's largely a biomarker of organic anions. And so when we calculated what this acid production was, and we looked with higher acid production, so here's higher acid production in quartile 4, lowest in quartile 1, we looked to see, well, does this look reliable? Do we see readout in bicarbonate if we are looking at patients with higher acid production? And so bicarbonate's falling here to the right, a very small signal in patients with early CKD related to lowering acid loading. And that's just a summary slide. So what are the types of foods if we're talking about doing this through a dietary approach? Foods that are lower in acid load are things that are generally healthy for you. Fruits and vegetables, low-fat dairy products. Some vegetarian proteins are going to tend towards either more base producing or at least less acid producing compared to higher animal protein sources. And one dietary intake pattern that's commonly recommended in clinical practice is a dietary approach as a stop hypertension pattern. So this pattern is characterized by a higher intake of fruits and vegetables, low-fat dairy, lean proteins, and reduction in red meats and sweets. And basically, if you calculate what the net endogenous acid production of that diet would be, the DASH diet here is what we call the combination diet in this trial. It is lower than typical American consumption of 78. So this is basically calculating the different interventions in the DASH trial, which was typical American consumption, augmented fruits and vegetables, or the combination, which augmented fruits and vegetables and reduced red meats, along with a few other changes. And you can see it can be done without lowering protein. In fact, protein intake was higher, but it's really done by augmenting fruits and vegetables. And very briefly, we have very little data about dietary patterns in CKD, but one of the few studies out there is from the Nurses' Health Study. They looked at compliance with a DASH-style dietary pattern based on food frequency questioning and targeting sort of biologically plausible pathways that may mitigate some of the change in GFR that we've observed over the last decade. I'll move on. To close, I'll just show you a few of the things that I'm doing now or I'd like to do, but what are the potential applications? Because a lot of people say, well, modifying diet is hard, and a modifying diet is very hard. But there are population approaches and patient approaches that we could consider. One population approach is sort of attacking the food environment and making it easier for people to consume healthy diets. So, if you're not aware, there are areas in the United States that are largely considered to have poor access to healthy foods. So these are census tracts across the United States that have limited access to a full-service grocery store or supermarket, and in which patients eat less fruits and vegetables and fresh foods. And so we were curious whether living in a food desert would be associated with more kidney disease. Here we looked at blood pressure, and you could see here patients that were living in food desert census tracts had higher blood pressure compared to those that were not, 1.5 millimeters of mercury higher. And if you compare that to the impact of poverty on blood pressure, it's reasonably comparable. So these are people with a family income ratio, income to the poverty ratio here greater than 3, and people here living. That I'm very interested in my future work is understanding whether we can identify a early acid-base biomarker, and one that could help us target acid-base abnormalities earlier in CKD, perhaps through dietary interventions. I put this up just as a way to show you what the possible targets could be. I think I told you ammonium here is a major mechanism that we excrete acid. So we could look at total acid excretion as that biomarker. We could also look at physiologically how we generate ammonium, which is basically by converting glutamine to 2-oxoglutarate in the kidney. And so might there be metabolic changes in metabolic pathways that show us that patients are revving up generation of ammonium, and could be metabolomic pathways to target with dietary intervention. So this is an area that I'm currently working on in looking at changes in metabolomic pathways, amino acids, and some of these different variables in patients fed low dietary acid load diets or given alkali supplements. So in summary, I hope I convinced you that kidney disease, even mild decreases in kidney disease, are important to prevent, that there are physiologic adaptations of this inhibitor, and we're controlling your blood pressure. And a lot of patients feel that that's not what they can do. And so there's sort of the locus of control of that intervention is sort of outside of them. So I think, I don't know how many people would change from direct patient management, dietary advice, but I think there certainly are patients that are